Hi, my name is April Shank, and I will be talking about quality improvement in patient care amid the COVID-19 pandemic. I apologize ahead of time that you can't see me in this lecture, but it was my intentions for me to be visual in the lecture with my slideshow, or with the presentation slides. Okay, so again, I'll be talking about quality improvement in patient care amid the COVID-19 pandemic. So the goal of this class today will be that the training is to educate nurses about quality improvement in patient care during this current pandemic. Quality improvement in patient assessment, patient oxygenation, and overall safety measures will help to improve patient outcomes. The purpose of quality improvement is to provide the best care and ensure the best patient outcomes. This is managed by research and changes based on evidence. First objective. Given a PowerPoint presentation and accompanying reference materials, nurses will be able to identify 2 quality improvement measures in the assessment of potential COVID-19 patients. Quality improvement in this instance refers to asking better assessment questions, not just asking how they feel, but how long have they felt this way. Sometimes practitioners look at a patient, see a symptom, and jumps to conclusions. It is important to be a little bit more thorough. It is important to remember that although intubation may seem extreme or an act of last resort, it will be the best interest of many patients to be intubated before they reach acute respiratory distress syndrome, also known as ARDS. Protection of personnel in the hospital starts with protection of the community at large. Protecting everyone truly protects everyone. Assessment. So a typical respiratory assessment. What symptoms and how long have you had them? So whatever they present with, you have to remember to ask them how long have they been having those type of symptoms. Any history of respiratory disease such as COPD, asthma, emphysema. If they've just gotten over pneumonia. You listen to the lung sounds. You would assess their cough if they had one, whether it's productive or non-productive, what the color is, if they've had any access to travel, what was their travel history, any history of smoking. These only tell half the picture. To be more thorough, we must prioritize. When looking at the assessment of patients that may or may not have COVID-19, it is imperative to get a good history of their symptoms, not just how long they have them, but where they have been in the last 2 to 3 weeks. Travel history is important, but it is second to knowing how long symptoms have been present. A person may have traveled around the world in the last week, but if their symptoms have been present for 2 months, they can quickly and easily be ruled out. Assessment, prioritize. So complete a detailed history and physical exam with extra attention to epidemiologic factors such as known exposure to an individual who has tested positive for SARS-CoV-2. Clinicians are strongly encouraged to test for other causes of respiratory illness, for example, influenza, in addition to testing for SARS-CoV-2. Prioritize testing of minimally symptomatic and even asymptomatic persons who are long-term care facility residents, especially in facilities where one or more other residents have been diagnosed with symptomatic or asymptomatic COVID-19. There's a reference down there from the CDC. Objective 2. Given the pathophysiology of the respiratory system, nurses will be able to identify 2 quality improvement measures in the treatment and improve oxygenation of patients infected with COVID-19 virus. Oxygenation and perfusion. COVID-19 confined to the conducting airways should be mild and treated symptomatically at home. However, COVID-19 that has progressed to the gas exchange units of the lung must be monitored carefully and supported to the best of our ability. We must intervene sooner. So when gas exchange takes place at the alveoli, and if we take too much time to determine whether or not we can get their saturations up, patients can deteriorate quickly. Assessments must be going on rapid. Patients should be intubated quicker and prone for better outcomes. And you can see this. By the start of your shift, you take care of a COVID patient, and by the end of the shift, they're intubated. They bypass the BiPAP now, but they do deteriorate really quick. GAP, escalation to invasive ventilation. So G is for gas exchange abnormality, A is for airway protection, and P is for pulmonary toilet. So for a gas exchange abnormality, COVID-19 respiratory failure is usually hypoxemic, not hypercarbic, worsening oxygenation. Their PaO2 and FiO2 or SpO2, and FiO2 is less than 150. NIV with FiO2 is greater than 0.6 and can't maintain SpO2 greater than 90. So PaO2 FiO2 ratio is the ratio of the arterial oxygen partial pressure to fractional inspired oxygen. So the FiO2 is expressed as a fraction, not a percentage. The PF ratio at sea level, the normal PaO2 FiO2 ratio is roughly 400 to 500. If 400 is what the average person walks around with, it is easy to see how a low PF ratio can be predictive of imminent respiratory failure. The key is to intervene sooner. Intubation sooner rather than later may be the key to saving more lives. Another reason for intubation is increased work of breathing suggests deterioration of respiratory functions. We have to protect their airway. We notice altered mental status can attribute to respiratory failure. They start having neurological dysfunctions, or if they have neurological dysfunctions, we have to remember airway protection. We will intubate to protect the airway. Pulmonary toilet is when you have increased airway secretions. So that is another reason why we would intubate. The early intubation strategy makes sense for two reasons. One, patients with COVID-19 can deteriorate rapidly. Example, from given minimal oxygen requirements to life-threatening hypoxemia and respiratory distress in hours. And second, it takes time to deal with logistical complexity of preparing for and performing intubation with patients with COVID-19. Objective 3. Given reference materials on personal protective equipment and infectious disease identification, nurses will be able to identify 2 quality improvement measures in providing for safety and protection of staff members when dealing with patients infected with COVID-19 virus. Personal protective equipment. Proper PPE use means protecting yourself, protect your patients, protect your facility, and protect your community. Reducing risk to the facility. Cancel elective procedures, and you've been seeing this happen in the last few months. They've only now started doing elective procedures, but with elective procedures, they're testing everybody to test for COVID if they're positive at COVID-19. So now, I don't know about other hospitals, but at Kaiser, we're testing before procedures. We do a pre-testing COVID for pre-procedure. Conduct most visits via telehealth, and I think this is still going on where appointments are being made through telehealth with an iPad or some type of tablet form, or they can use their phones. But internet is important at this point. Decreasing points of entry and exits. So there's only one way into the hospital and one way out for visitors. And they are also monitored for temperatures. So whoever comes into the hospital, Kaiser is not testing their employees, but they do test every visitor that walks through the lobby. And so they are screened for temperature, and they're asked the COVID pre-screening questions about traveling, if they've been in contact with anybody. So that is another way of reducing the risk to the facility. Volunteers aren't volunteering right now, and everyone must have a mask when they enter the facility. see, the number of people need to be controlled, limit pharmaceutical reps and salespersons. So basically, pharmaceutical reps and salespersons, even with palliative, hospice people, they weren't able to come and see the patients unless doctor found it imminent and they need to go to hospice, and that's the only time they couldn't come and screen people or anything. They would work with the case managers. So it's not enough to control the flow of people through the facility. So these are just little things that they were doing to help reduce the risk of COVID coming into the facility. So then we would isolate symptomatic patients as soon as possible. We'd place patients with suspicious symptoms in a room with a closed door, ensure that if there are several people waiting, they have room for social distancing, prepare for a large number of patients to be screened, have a large area ready, establish triage protocols to manage patients quickly and efficiently. When symptomatic individuals are ruled out, send them home as soon as possible. Do not keep them in the facility any longer than necessary. So basically, if patients needed to be admitted, they were admitted. If it wasn't emergent, they'd be taken care of at home. Medicines, they pick up their medicines and they would go at our place. The ER was triaging everybody. They weren't automatically let into the front door, and they would be triaged there. Doctors were talking to people over the telepad, so it was really no contact, basically. And when they were admitted into the hospital, it was all about gowning up and having the right protective equipment on. So next, protecting staff. All healthcare personnel interacting with COVID-19 positive patients need to use a face mask or respirator, no exceptions. Discussing the donning and doffing of PPE with every shift. Reinforce hand hygiene, use of sanitizers with all non-patient facing staff members. Remind staff members about hand hygiene after removal of PPE. Remind staff members to stay home when not feeling well, and consider outside areas for triage if possible. So discussing the various isolation types and procedures. Basically, there's 3 types of isolations, and that is droplet, contact, and airborne. When people would come in when COVID-19 patients were isolated, we had to use an N95 mask or a 1860 mask when we were ruling out if they were positive and they were getting aerosol, they're considered airborne. If they were only getting inhalers, then they were considered droplet. So there's those different types, and then they always have somebody that they call a spotter to make sure that when they're donning, they're doing it correctly and it's on correct, and when they're doffing, they're taking it off correctly and didn't miss anything. So there's always a spotter watching. If there's a step missed or something, they notice something that person doesn't see, then they're able to help that person. So teamwork is a big thing. And then you have conclusion. So this pretty much sums it up. I hope you enjoyed the presentation. Again, I'm sorry I wasn't able to do the whole thing the way I wanted to, but I hope you learned some things out of this. Normally there would be a pre and post test given after the lecture. Okay, thank you very much.